from AIMS will now give us a talk on microsporidiosis, especially challenges in managing the condition.
Yeah. Thank you, Dr.
Yours
Anita.
was good.
At the outset, I thank the scientific committee for making our course a part of this wonderful program. I have no financial interest to declare uh, to the course of my talk. I think I'm going to take you through the challenges in managing microsporadial keratitis. I think before I begin, can I have a show of hands of how many of you have managed or have seen microsporadial
I
keratitis?
said, you need to help
Okay,
me look
yeah.
for it.
So I think the majority of you will probably have something to take home from my talk over the next 10 minutes here. And very few people having seen microbial keratitis. Why is it so? Because it is a rare infection affecting the cornea. The incidences are reported to be approximately about 0.4% of all cases of microbial keratitis. That's the first reason why we all see very less of microsporadial keratitis. But that said, it's not only it's not only because of its rarity, it's also because of the difficulty in diagnosing microsporadial keratitis. I'm sorry for the alignment of the boxes because this computer seems to have changed these. When you look at clinical presentation of microsporadial keratitis, it primarily presents in two forms. What we would commonly see is a microsporadial keratoconjunctivitis, which is the more common form, and I'm sure most of us would have definitely seen it. The reason we don't probably pick it up is it's a fleeting condition and several times tends to be self-limiting, and the cornea, the epithelial keratitis lesions do disappear most of the time with the frequent fluoroquinolone antimicrobial therapy we tend to give for all conjunctivitis. So that's commonly the reason why we probably several times do tend to miss a microsporadial keratoconjunctivitis. That said and done, what is more difficult to see and handle is the second form of the keratitis, which is the microsporadial stromal keratitis. This closely mimics a fungal keratitis or a viral stromal keratitis here. So it commonly is very difficult to pick up on your microscopy slides and smears here unless you have a well-trained microbiologist who is going to be looking at it only if you raise the suspicion of a microsporidia to your microbiologist. So that's the reason why we commonly land up missing a microsporadial stromal keratitis here, and several times it lands up as a chronic keratitis which is refractory to the management to the antifungal therapy which we are giving. So this primarily is a very important challenge which I feel in managing microsporadial keratitis. I have been in cornea for over 2 decades now, but still I have a difficulty of placing microsporadial stromal keratitis on the top of the diagnosis of my list, and I'll be honest about it. Probably I'm missing it, or more so it's because we are in a tertiary care, and by the time the patient comes to us, it is handled by multiple corneal physicians, so I cannot make a straightforward textbook diagnosis of a microsporadial stromal keratitis. So please remember, microsporadial stromal keratitis can closely mimic a fungal, a bacterial, can mimic a herpetic keratitis, and all these commonly tend to delay the diagnosis, thereby making the treatment, a successful treatment outcome, more challenging in these scenarios here. Okay. So we'll just look at a few diagnostic slides here. Smear examination is mostly diagnostic for these organisms, but that happens when you have a clinical diagnosis or a clinical query in your mind here. And a simple smear, it could be an acid-fast stain. What is characteristic is a trichrome stain here. You could look at chalcophore, but chalcophore will need a immunofluorescent microscope to look through it, and you would look at these, you would get these intracellular oval bodies which were very characteristic appearance of microsporidia here. I thank Anita for providing me these fantastic pictures here. So again, these are acid-fast stains where you could pick up these oval body, intracellular bodies here, and confocal microscopy. The appearance of microsporidia would look a little different, and it is slightly larger as compared to your acanthamoeba sets here. So that would also ring a bell to tell you that this is probably microsporidia you're looking at. Again, these are fantastic diagnostic slides here from this article in ophthalmology in 2006 here. The top picture is a picture of chalcophore white staining, and through a fluorescent microscope where you do see typically oval and oblong fluorescent like structures here. And the lower one is an acid-fast stain on a 500x magnification where the microsporidia appear as bright red oval bodies here. And this is not something which you would commonly see, and you would need to alert your microbiologist to pick up these for you in case your clinical diagnosis is high on your mind here. So how do we differentiate, or what are the clinical characteristics between a keratoconjunctivitis and between a stromal keratitis caused by microsporidia? The risk factor is almost similar as you would have for acanthamoeba or fungal here. Usually a history of trauma, contact with contaminated water or soil. Could have contact lens wear here, but in India, beware that microsporidial keratitis, keratoconjunctivitis can be without contact lens wear as well, but it has been reported to occur at a higher frequency with those who are using contact lenses here. The clinical presentation is similar as for any other epithelial keratitis here: photophobia, redness, watering, foreign body sensation. Impairment of vision is not a particular problem when you look at keratoconjunctivitis, and pain is more significant in terms of when the presentation is a stromal keratitis and the associated ocular inflammation which comes along with it here. Slit lamp findings, you would find grayish, coarse epithelial. In epithelial, it would look like something is stuck on to the epitheliums. That is very characteristic, and you would really not miss it when you look at it. And the conjunctival injection would not be very severe in these cases. You will have it probably very mild, and when these patients report on early, they just complain of a foreign body sensation is what they would probably come up to you, and several times it's a self-limiting lesion. It would just go away with whatever antibiotic you're treating them with. Whereas in a multifocal stromal infiltrate here, primarily it would appear as a stromal infiltrate here, or it could be a keratoconjunctivitis, an epithelial keratitis which is progressing on in the terms of a chronicity and going on to a deeper infiltration here. I'll show you subsequent pictures on that, and we can talk more about it then. The differential diagnosis when you're looking at a keratoconjunctivitis would be, the top ones would be your thygosins here, superficial punctate keratitis, but it can mimic acanthamoeba, mycobacteria, adenoviral. I'm stressing on this because several times we always land up not diagnosing a microsporidia and diagnosing it the other way around. Diagnostic techniques, I still feel it's largely a clinical diagnosis when it's keratoconjunctivitis, and it's when it's a refractory stromal keratitis do we think about looking at microsporidia in our microbial investigations here. Treatment options are definitely limited. I'll just come to it during the course of the next few slides. And the thing to emphasize here, or thing for you to take home from this, is that microsporidial stromal keratitis medical management is commonly not very successful, and you would probably want to resort to an early keratoplasty in these scenarios here. Okay, so so to elaborate more on the challenges, a clinical history, contact with recreational water. So during football or something like a sports injuries where it's going to push in dirty water into your eyes here, and the history of insect bites are the two common clinical history which is associated with microsporidial keratitis. Whenever you look at a multifocal epithelial keratitis, you're seeing a chronic stromal edema with infiltrates here, which is non-resolving to your conventional management here. Appearance of a granular keratitis and a refractory to your medical management, you would probably, all these would red flag and raise the suspicion of microsporidial keratitis to you. So these are clinical pictures of the two presentations of microsporidial keratitis here. This is the one which you would commonly see. They look like simple stuck-on lesions here with your conjunctival hyperemia not being very bad in the early cases here, and with treatment this just goes away, and you see them perhaps a week down the line. You would really doubt if this was the same eye which you are looking at. But that said, in some cases you do have a mild stromal haze which goes subepithelial and into the anterior stroma sometimes here, and this might haze or increase or become a subepithelial haze with the disappearing of the stromal of the epithelial lesions here. And when you look at a patient at this stage is when you tend to confuse it with an adenoviral keratoconjunctivitis here, because adenoviral, you would probably think this is a subepithelial immune haze which is occurring because of adenoviral here. So again, remember, these lesions also are immune lesions to the epithelial infiltrates, and if they are self-limiting, they are going to be going away. But if you would find a patient coming to you on the second or the third week following a primary keratoconjunctivitis lesion, you have immune infiltrates in the cornea, and you can have an associated iritis as well. So that's why I would probably red flag and call my patients back 2 weeks down the line following a diagnosis of a microsporidial keratoconjunctivitis to rule out an immune infiltrate here. If the lesion is going to progress further, then you would land up having a microsporidial stromal keratitis, a very classical picture like this as you're seeing here. ASOCT would help you if you are in doubt, where you could look at the level of the infiltrations, whether it is epithelial or a subepithelial here, and when it is associated with the coarse granular infiltrates of the surface, it's a clear-cut picture of a microsporidia. But when you look at an adenoviral, you would see your epithelium is largely not disturbed. It's more of an epithelial punctate keratopathy, and the subepithelial haze is more well defined when you look at adenoviral keratoconjunctivitis here. I'll just show you a couple of these. These are from literature, but they are very interesting articles which have shared their experiences in the management of microsporidial keratitis. And look at these varied pictures. Look at the clinical variation in the presentations of all these. And I would be very honest and say I would have probably diagnosed these as fungal keratitis. I think the panelists and the experts sitting here would also agree to this. We would all look at it and think of this as a fungal keratitis when you look at these patients. Again, more pictures here, and this is a fantastic article which talks about grading microsporidial keratoconjunctivitis or stromal keratitis as 1, 2, 3, and 4, depending upon the number of infiltrates which you're seeing on the corneal surface. Less than 10 is 1, 10 to 20 moves it to 2, and over 20 to 40 it moves it to 3, and large infiltrates and stromal moves it to a grade 4. This is a nice recent classification which helps you to grade the severity of the microsporidial keratitis here. Think apart from diagnosis, then what's the challenge in managing these lesions is the availability of medications we have in our armamentarium to manage these infections. So always what is classically said is Fumagillin 1 hourly for 7 days is probably going to be very effective in managing this. That said and done, I've never used Fumagillin, primarily because it's not accessible to us in India here. So there are varied management modalities described in literature for microsporidial stromal keratitis, starting from oral albendazole, oral itraconazole, topical fluoroquinolone therapies is what we commonly resort to. It also responds to topical voriconazole, and anti-acanthamoeba treatment has also been tried in these cases here. So remember, most of the time the treatment is long drawn when you're looking at microsporidial keratitis, and several people have reported their experience, and I think Anita Raghavan here is one of the people who have a fantastic experience with managing microsporidial keratitis. It's a really recommended read, which I would ask you all to go back and look at and improve your knowledge on the treatment modalities for microsporidial keratitis. I'll close here and thank you very much for